Good evening, everyone. I welcome you all for this second session of Fetal and Neonatal Neurology SIG. And today we have another interesting session on neurology. We have an interesting webinar followed by five interesting case presentations. I would request the President Dr. Chapalavote ma'am to introduce the today's speaker, today's moderator, and the experts for today's session. Over to you, ma'am.
Thanks, Mahesh, and welcome you for the next talk on neonatal neurology and fetal neurology series. So we're focusing on neonatal EEG monitoring, current practice with future perspectives, and amplitude integrated EEG and its current role in practice. And we have amazing speaker, Dr. Ronit Pressler, who is consultant in clinical neurophysiology, Great Ormond Street Hospital, London, and associate professor of clinical neuroscience, UCL Institute of Child Health. And we have four experts. We have Dr. Dilek Yalnizoglu from Turkey, Dr. Shehnaz Ibrahim from Pakistan, Professor Lakshmi Nagarajan from Australia, Perth. She's Secretary of International Child Neurology Association, and she was kind enough to be there last week, and Dr. Mary Ipe from Trivandrum. And to moderate the sessions would be Dr. KP Vinayan from Kochi. And we'll have 5 case presentations, one from Pakistan and rest from across India. So Dr. Ronit Plesser has a consultant in neurophysiology, clinical neurophysiology is Gosh, and she was consultant in clinical neurophysiology in Cambridge University Hospital and in the UCL. And her research interests are on neonatal seizures, particularly their diagnosis and treatment, and interested in neonatal and pediatric EEGs, and chairing a number of international task forces workshops on neonatal seizures involving ILE, neonatal seizure classification task force, and the neonatal guidelines. And she's co-director of the ILE course EEG in the first year of life. So we have the best possible person, I suppose, globally, and to talk on this topic. And then we have Dr. Shehnaz Ibrahim, who is Professor of Pediatric Neurology from Departments of Pediatrics and Child Health at Aga Khan University, Karachi, Pakistan. And she has special interest in child development and disability, and has been doing a lot of research projects and has had multiple awards, and chair of many committees and president Pakistan Pediatric Neurology chapter, and has many positions in many associations. And Professor Lakshmi, who is Secretary, International Child Neurology Association, child neurologist and epileptologist from Perth Children's Hospital, Australia, and clinical lead epilepsy and neurophysiology, and clinical professor of UWA Medical School. Her special interests are in epilepsies and especially in small children. And we're really grateful to her. And you can go back to our YouTube for the neonatal seizures talk she had taken in November during the epilepsy SIG. Dr. Mary Ipe, she's professor and head of Department of Pediatric Neurology, Government Medical College, Trivandrum, and she's regional director and visiting professor in the Institute of Communicative and Cognitive Neurosciences. And she has multiple awards and to her credit, and she is past president Kerala Neuro chapter of the IAP and executive committee member of NSI. And we have we have from Turkey. Can I have the next slide, please?
I'm just showing just 1 minute.
Yeah. So it's okay. Then we have Dr. Dilek from Turkey. Can you show her slide, please? And we have been having different, resource settings, experts, so that, the discussion becomes really very rich when we have such great experts coming. And from Turkey, we have been also having Dr. Hassan, who has been supporting this series. And you have the slide, please?
Ma'am, just give me a moment, please.
Okay, no problem. So before, by the time she gets, so we will be having the moderator, Dr. Vinay, who has also have a lot of research, interest in neonatal seizures and neonatal EEGs. And I'll be handing it over to him after I introduce Dr. Dilek, who's come first time as an expert from Turkey. It's okay if I can, if you don't have the slide, it's okay. I have the slide. I can read it out. I'm sorry that she didn't get it. Dr. Dilek Yalnizoglu, she's a professor in pediatrics and pediatric neurology at the Heritage University Children's Hospital, Chief Department of Pediatric Neurology from Ankara, Turkey. She has her MD degree from Ankara University Faculty of Medicine, Ankara, and pediatric residency and pediatric neurology fellowship at the Hacettepe University Faculty of Medicine, Ankara, Turkey. And she has clinical neurophysiology and epilepsy fellowship at the Boston Children's Hospital, Boston. And her research areas are pediatric epilepsy, epilepsy surgeries, rare metabolic and neurogenetic disorders, and she is chair of the EPNS Committee of National Training Advisors. We really welcome all on this platform, and I hand over to Dr. Vinayan for the conducting and moderating the session. Thank you.
Some questions here. And Mahesh, how much time we have? Anyway, we'll
we can ask Vinayan. We can ask those experts their comments, and then you can take the questions. Yeah.
Okay. So I think Dr. Lakshmi is there? Hello?
Yeah, Lakshmi is there.
So anything to add, or you would like to have your comments on this talk?
Thank you very much, Ronit, for a wonderful overview of the role of EEG in the neonatal arena, especially with regard to background and seizure detection. I think I totally agree with you that paroxysmal events in babies are very frequent and sometimes very difficult to distinguish whether they're epileptic or not without an EEG. And I think that we all have to be pragmatic across the world. In Australia, we do not have continuous EEG monitoring for at-risk infants in any of our hospitals. The times we've done it is as part of a study only, and our results are similar to results across the world, that EEG is far inferior to having conventional EEG, and that while EEG is useful to detect babies with seizures, it's not as good for seizures in babies, the total number of seizures, the seizure burden. And the other problem with using EEG alone is the number of babies that get treated with anti-seizure medications who actually do not have epileptic seizures. And therefore, I think we all need, it's imperative for all of us to work towards getting conventional EEG everywhere and using a pragmatic combination of conventional EEG, AEG, and clinical acumen to get the best outcomes in babies with seizures. And all the new advances are very exciting, and look forward to seeing where QEEG leads us to in the long run. And AI, of course, in every aspect of pediatric neurology as well as other aspects of medicine is something we all have to keep abreast of. And thank you, Ronnie, for an excellent overview.
Thank you.
So, Dr. Dilek?
Thank you, Dr. Kessler, for this great talk and comprehensive presentation. One of the take-home messages, I think, from this presentation was that, resources may vary between countries and even in different centers in a certain country, but there's still, as clinicians, that we can do, such as implementing a seizure treatment plan and protocol, as you mentioned in your talk. So even if we have limited access to EEG, AEG, or even if we do not have a continuous EEG equipment or a staff for that, there are things that we can still do to promote brain health of these babies, and we can establish a seizure treatment plan and something that can speed up our control of seizures and status. So thank you very much for mentioning this too. Thank you.
Yeah, that's a great comment. Actually, improving the brain health is the ultimate goal of all this. Now the comments from the subcontinent, Professor Shahnaz Ibrahim, Pakistan.
Hi, good evening. I really appreciate this session on the neonatal EEG. And yes, there are places where we don't even have an ambulatory EEG. So it becomes difficult. At our center, we do have the AEG and the regular EEG. And sometimes when neonates have severe HIE, we do have a continuous EEG monitoring available for us. But again, it's different across different centers, as was mentioned by Dilek. In our country, because of the perinatal asphyxia, HIE, it's very, very common to have severe HIE. And my question to Ronit would also be that the current recommendations for ILE says that whatever the state of the HIE, if the seizure stops 72 hours before discharge, then you stop the anti-seizure medications. And that's a matter of a little bit, for me, it's a little confusing because if the neonate has had seizures which were difficult to control and is seizure-free on medications 72 hours before discharge, would you still consider stopping the medications? And if the EEG is, say, showing some abnormalities or the EEG is absolutely normal at that point, would you still stop it?
So I agree. It can be tricky, but generally speaking, we recommend to stop medication before discharge. Obviously, you shouldn't if the baby was treated successfully. If you have, obviously, you can't stop the medication and send the baby home the same day because you need to observe the baby whether seizures return. So this is why you have to do it a few days before discharge. If a baby responded to phenobarbital itself, so using phenobarbital as first line and the baby responded, then definitely we would recommend to stop medication even if the EEG is abnormal. If the EEG shows seizures, then not, because then that wasn't successful treatment. But all babies with HIE have some abnormalities, so that is not an indication not to stop. The study by the US Neonatal Registry has shown that if you stop medication or if you continue medication, then you do not reduce the risk of later epilepsy. So therefore, the ILE task force has, or the expert opinion is to stop medication if you were able to treat successfully. If you have a baby with 2 medications, I would also recommend to stop. If it was very difficult and it took several weeks to stop the medication, then obviously this is different. And then you may want to stop 1 or 2 drugs and continue with one for a bit longer because it's difficult to stop so many medications. But there are no data. This is just my opinion. If it becomes complicated, there is no data. We don't know. There's nothing we can say.
Thank you.
So
and thank you. That was an excellent session for the understanding of when to do the EEGs and how they would be able to sort of how interpretation of that would help us in predicting what the child will have in the future, because that's a very common question that families ask us: what is going to happen and what is the prognosis for these children? Thank you.
Okay, so that opens up
Can I make a comment, Vinay?
Yeah. Why not?
I think it's a very good question that Shana has raised. And I think a lot of with regards to do we stop medications in everyone who's had neonatal seizures because of HIE? I think it's the data on which it was based when there was monitoring. But a lot of centers do not have monitoring, and you may have just one EEG or not. And we know there are lots of electrographic seizures without any clinical correlates. And there's a small percentage of babies with HIE who do not stop having seizures and just continue. And the seizures need not necessarily be clinical seizures. So I think there's caution, and we have to use, like personalized medicine in individual cases and make a decision. But on the whole, it is fairly safe to stop medications in most babies with HIE before you discharge them.
very, absolutely. I couldn't agree more. Thank you.
Yeah, that's a great comment. I think because of the lack of time, we have to go on to the next expert, Dr. Hassan.
Yeah, thank you. Ronnie, thank you very much for your excellent presentation. I really enjoyed the picture, maybe the last or before the last one, a baby has a book on the hands, the neural newborn networks. You know, we have continuous EEG, we have the integrated EEG. We extensively use both of them, hypoxic ischemic brain injury or hypoxic ischemic, all the for capture the neonatal seizure. And in the future, I believe we are going to continue to use both of them to define the neural networks in the neonatal brain, to compare the outside of the neonatal intensive care unit and the follow-up. We will combine the EEG with EEG connectivity with the MRI connectivity, and then we maybe clearly define the long-term outcome in the future perspective. And also, I really enjoyed your future perspective about the new trends, and then QEEG, and also another EEG modality. I think it may be evolved, that high frequency EEG for the neonatal babies. What do you think about in the future high frequency EEG in the
I think it might. I mean, there have been a couple of papers coming out very recently. High frequency EEG is very prone to artifact. So it's technically extremely difficult, and I doubt that it will have a role in clinical practice in the near future, but maybe later in 10 years or so. But yeah, it's very interesting. I agree.
Thank you.
Ronit, it was an excellent talk. Actually, last week we had Sudhin who was presenting about neonatal HI.
Yes.
And Lakshmi had a question for the EEGs in that study. So I think, Lakshmi, you can ask the question now to Ronit, because he marked it to you last time and he's on travel right now, so we couldn't have him today. Yeah. Lakshmi, you can.
The question I asked was whether in your PREVENT study, are you looking at the EEG that's being obtained to distinguish between acute and subacute injury? Like, are you looking at separately at amplitude suppression versus dysmaturity and disorganization to predict outcomes or for therapeutic interventions? So the main aim of PREVENT was obviously to look at the number of babies with encephalopathy. And so it was mostly used to determine the grading of the encephalopathy and the seizure detection. That was the main aim. And is that, so we didn't look at any other things, and they didn't use AEG. It was pure EEG. Could we look at the other things? Absolutely. We have, I mean, it's amazing the quality of data we have and the amount of data. It's such a rich set of data, and I think it's really important to look at more things. Absolutely, I agree. Particularly because it's the outcome of all these babies.
Yeah.
Can you just see any one or two questions important before we go to the cases? Because any question? Pressing questions from the Q&A?
Mostly the questions are all on neonatal seizures, but no, the one question I think is specifically on repeating the EEG. So how to repeat the EEG when you are having a seizure freedom before stopping medicines. I think we have actually discussed that.
Yeah.
And yeah, Ronnie.
Maybe the only thing to add to this is that usually what happens is if you have a baby with HIE who is critically ill, then most of these seizures are electrographic. But if you're looking at a week or 2 weeks later, then seizure become usually clinically, and you can use clinical judgment as well. If you can repeat the EEG, obviously that's great and very helpful. But at the age of 2, 3, 4 weeks, then most seizures are clinical and not electrographic anymore.
Okay, so then there is a question on this uncoupling. So there is a specific question. Phenobarbital produces uncoupling.
Mhm.
So then we should consider levetiracetam when there is no EEG monitoring available. So
No.
what is your take?
No, it should still be phenobarbital because levetiracetam, at least at the current dose which is recommended, is not very helpful. The Sharpe study showed that up to 28% of babies respond to to levetiracetam, whereas 80% respond to phenobarbital. So whatever you do, phenobarbital should be first line in every baby. There's no question, even if you can't monitor.
Now, Ronit, can you explain that a little? See, this uncoupling, is it because of the success of phenobarbital in controlling seizures, clinical seizures?
So, yeah, I mean, one thing to say is that we've just published a paper which shows that levetiracetam can also cause uncoupling. Not as often, but in a quarter of all babies, you still have uncoupling in levetiracetam also. So the only option would be not to treat at all, and that's not an option. So the idea is that uncoupling is due to the medication changing the propagation. So we know that phenobarbital reduces the propagation of the seizure, and then it might be that the seizure is not propagating to the motor area anymore. If it stays very focal, you are more likely to have subclinical seizures.
And then the uncoupling can occur at any age, no? See, is it just, it is a critically ill brain can have this critical uncoupling?
Absolutely. So you see this in older children as well. Maybe not as frequently, but you see it as well in any kind of comatose patient, ITU patient. Absolutely.
Yeah. So that is the message. See, it's a critically ill brain or a encephalopathic, severely encephalopathic brain can show this uncoupling when we have a successful control of the clinical seizures. So it is not AESM specific in that sense. So don't take that message from then say that the EEG monitoring, if it's not available, we'll use levetiracetam, and phenobarbital is more prone for uncoupling. So the other, yeah, any other questions? Any other comments here?
I think the uncoupling can occur even without phenobarb. It's not necessarily just because of medications.
Absolutely.
And a lot of babies show both, electrographic only seizures and electroclinical seizures. The percentage may vary in each baby, and some babies show only one or the other.
Absolutely.
So, and then there is a question on apnea as a clinical seizure. And is there any relation between what are the any factors which we will suggest to say that this apnea is a clinical seizure or a neonatal seizure rather than?
Very good question. Really important question. So altogether, I would say most apnea are not seizures. Really, the vast majority of apnea are not seizures. Usually, if you have apnea as a seizure manifestation, then there are other semiologies as well. You might have some kind of clonic movements, tonic movements, something else. But very rarely you have only apnea, but the risk of overtreatment is huge because the vast majority are not. Apnea, to diagnose apnea clinically as seizures, if you have only isolated apnea, I would say nearly always it's not a seizure. I would be very careful. I think there's a real risk that we overtreat on a clinical basis. What you can see is that people, and we saw this in the PREVENT study, people see little twitches, little jerks, apnea, change in heart rate, and misinterpret this as seizures. And when we do an EEG, we can't see the seizures. I think that's nearly as big a problem as underdiagnosing subclinical seizures.
And one more question is role of EEG when there is a brain death in the newborn. So what is your current guideline for that?
For brain
death, neonatal brain death.
Excellent question. So it's very clear you cannot use the EEG for brain death. Diagnosis of brain death under 1 month of age, you cannot use the EEG. A flat EEG is not indicative of brain death in neonates. You can have a flat EEG after birth for several hours, and have a normal outcome. You cannot use a flat EEG. It's very dangerous if you would.
Okay.
Yeah, I have a caveat, unless it persists.
Unless it persists, but even if it persists for up to, then you have brain damage, but brain death, it's very difficult. I mean, it has to persist for several days, but yeah, absolutely. The continuation is very important. I agree.
Like Ronit, we have this thing that we give take-home messages at the end, because you may leave before the end of the cases which we start. So can you give us take-home messages to our attendees, and the rest of the experts will request them to give them in the end, but because you may leave in between, so before we begin the cases, so can you please give some take-home messages, because that's the protocol. Like, we want a message given, although you have the take-home message slides and all, but whatever you feel like you want to keep it in their mind.
So my take-home message would be EEG is the gold standard, and if you can do EEG, it's great. AEG is a very, very important tool, and it can really improve the management of babies, but it's also important that we use our clinical skills and look at the seizures. Don't overtreat, and try not to undertreat as well. But yeah, using the combination of EEG, AEG, and clinical clinical diagnostic skills is really what is the most important thing.
Yeah.
You please stay on till as long as you can, and Dr. Vinayan will conduct.
Yeah, thank you. Thank you, Ronit. It was really wonderful to have that session, and I hope we will have more interactions with our students and residents here in the years to come. So we will go to the next session, that is our case presentation from the residents and fellows. The first case is from Pakistan, Lahore, University of Child Health Sciences, Dr. Rasa Kaveria Rasa. And the moderator is Dr. Shanas.
So Mahesh, you want to make the housekeeping announcement and for the case?
Yeah, that's better because it's already late.
Yeah, we're running late. Mahesh, housekeeping announcement.
Each presenter will be given 6 minutes to present the case, and we'll be giving 2 minutes for discussion. Request all the presenters to stick to the time, and I'll be giving a reminder at the end of 6 minutes. We have about 5 cases, so we need to finish all the 5 cases. So please stick to the time. Thank you.
Okay, Dr. Alvi.
Good evening, everybody. I'm first of all very thankful to the AOC in India for giving us this opportunity to present here. Should I start?
Yes, yes.
The screen is visible?
Yes, very well.
Okay, thank you. So today I'm going to talk about neonatal seizures as an onset of inborn error of metabolism. So neonatal seizures, they pose an important emergency that requires a rapid diagnostic workup in order to initiate prompt therapy and improve the outcomes. The group of inborn error of metabolisms, they present with a variety of non-specific signs and symptoms and sometimes become challenging. They may be associated with metabolic decompensation if they are severe in nature, and we should suspect them if the seizures are resistant to the common anti-seizure medication. So this case is about a 7-day-old baby boy who came to us with episodes of tonic posturing for last 2 days. That is, the onset started at day 5 of life. This was associated with reluctance to feed, lethargy, and respiratory difficulty. Talking about the birth history, baby was born by C-section at 37 weeks in a periphery hospital with no antenatal or no immediate perinatal complications. His weight was 2.6 kg and the OFC was 34.6. Regarding the family history, now this is very important because the child was born to non-consanguineous parents. And if you see that there are 2 miscarriages and there are 2 neonatal deaths, one being male and the other being female. Both of them had onset of seizures at day 5 of life, and the boy expired at 25th day of life. The girl expired at 7th day of life, and they both were labeled as meningitis versus early onset sepsis, especially in the girl. And this is our index child. So when we received the neonate, he was very sick with breathing difficulty, mainly because of acidosis, full rather bulging atria fontanelle and lethargy. There was central hypotonia, poor neonatal reflexes, but there were no localizing signs and the pupils were equal. So the child was immediately shifted to NICU. And these were the videos that we, okay. So these were the videos that, okay, the videos are not playing for some reason. But anyway, you can see the posture. So he had episodes of tonic movements of the limbs, sometimes upper and sometimes lower with fisting, but there was no cyanosis and there were no uprolling of eyes or a staring gaze. And when this episodes were over, the child was centrally hypotonic in between. During the NICU stay, we also observed that he has intermittent apneas, boxing cyclic limb movements with progressive worsening in lethargy and central hypotonia. And during the course of illness, they after 10th day of life, they were also change in the seizure semiology, progressing to tonic spasms, roving limb movements, and focal clonic seizures. So these were the investigation that was done during the course. The CBC showed a normal hemogram with normal serum electrolytes and normal bone profile. But the ABGs showed severe metabolic acidosis with pH of 6.9 and bicarb of 6. To rule out the infectious etiological factors, the CSF was done, which was negative, along with the cultures. So this ABGs showing severe metabolic acidosis was immediately corrected with fluid boluses, bicarb infusions, and meanwhile we got a cranial scan which actually showed the effacement of the sulcal gyral pattern, and they were echogenic foci mainly in the thalami. So we went ahead, and after stabilization, when we could move the child, we got an MRI brain. Which actually showed, if you see signal alteration in the posterior limb of the internal capsule as well as the thalami and in the midbrain. During the course, there were 2 EEGs of this child done. The first was normal, that was done immediately after admission, and the second was done around 15th day of life. This is a short-term interdictal EEG which showed sharp wave discharges, and these were seen frequently. I've just put one tracing of it. So considering the consanguinity SIB deaths with the same course, acidosis on presentation and specific neuroimaging finding, we extended the workup for metabolic error, and we found raised anion gap, ketosis, hyperammonemia with a normal lactate. So here this limb with metabolic acidosis, normal lactate, urinary ketones. So we immediately send the organic acids and the plasma amino acids. The plasma amino acid quantification showed marked elevation in the leucine, isoleucine, and valine. So these are the branch chain amino acids which starts to accumulate when there is deficiency of the branch chain keto acid dehydrogenase complex, and the respective keto acids starts to come in the urine, and there was marked excretion of the keto isocaproic acid, confirming the diagnosis of maple syrup urine disease. So we immediately tried to stabilize the child. We were correcting the acidosis from the start since the child came in, along with the management of seizures. So for seizure management, even with maximum doses of phenobarbital and then add on levetiracetam, we had to give phenytoin as well, along with the continuation of neuroprotective measures. There was central respiratory failure, because of which the child had to be intubated and ventilated. Brain edema was managed with mannitol. For the correction of metabolic derangements, we did give sodium benzoate and bicarb infusion because initially our diagnosis, considering metabolic errors, were NKH, MSUD, and maybe paradox-independent seizure. So we did consider the paradoxin in the treatment, and after the MRI, we immediately started thiamine. And the child was kept NPO and given dextrose-containing fluids. Dextrose-containing fluids, followed by protein restriction formula. After all these measures, the clinical course and the biochemical profile started to improve. Ammonia levels were improved, acidosis had improved, and the bicarb was now 14 milliequivalents. Here, at this point in time, we received the branch and amino acid peak on plasma amino acid quantification. So specific MSUD formula was initiated after consulting dietitian and a metabolic expert. So there was clinical improvement in terms of decline in seizure frequency, although they were still off and on present, and improved conscious level. And the parent counseling were done in detail about the metabolic nature of disease. So this is the last slide to show the summary of the events. So he presented at 7th day of life with bicycling movements, with a negative infection screen, acidosis, hyperammonemia. So we managed by controlling the seizures, correcting the acidosis, starting sodium benzoate, and kept him NPO. The neuroimaging gave us more clue with thalamic and brainstem altered signals, along with the posterior part of the internal capsules with the weighted amino acids. But this clue led us to start the thiamine as well with a protein-restricted formula. Then he had to be ventilated because of central respiratory failure. And here we got the peak of branching amino acids, which led us to start the MSUD specific formula and continued anti-seizure medication. With this, the clinical as well as the biochemical profile improved. The baseline metabolic markers were improved, although then he developed pneumonia and had to be managed on these lines. Thank you very much. I hope I was in time.
Yeah, it was really good presentation and a case with a message. And anything to add from the moderator or consultant, Dr. Shahnaz?
Dr. Shahnaz?
Can you? Yeah. So no, I don't think that there is anything to add. Metabolic disorders are very, very common in our country because we have a very high rate of consanguinity. So for us, neonatal seizures presentation, besides HIE, which is also very common, metabolic is something that we will always consider as a cause, and keeping in mind not only the organic acidemias, but non-ketotic hyperglycemia is also not uncommon. So these are this is a very classic presentation of an organic acidemia and well presented Javeria. But I don't know if anybody else has any questions, then maybe we can answer it together.
And before you ask anybody else, Dr. Mary, we missed your comments till now. Dr. Mary, and then Ronit.
Fine, that's fine. The presentation was very good. This case was even better. And I think regarding EEG monitoring, we have a very successful EEG monitoring in our neonatal ICU because we have an electrophysiologist who is available round the clock to interpret the amplitude integrated EEG, and well trained by Dr. Vinay at Amrita Institute. So if you have a parallel group who can, a paramedical group who can monitor the amplitude integrated, I think that's great.
Okay, thank you, Dr. Mary, for that. And Professor Lakshmi, anything to add?
Ronit wants to say something. Ronit has Dr. Ronit? Yeah.
So the only, thank you very much. Really interesting presentation. Very interesting.
Stop sharing the screen, Raza.
Thank you.
So I think what is really, I mean, you manage this child exactly as it should be. The only thing I could add is that actually maple syrup urine disease has a very specific EEG pattern. So if you do have EEG, you see those comb-like patterns, which are characteristic of maple syrup urine disease. And sometimes you can make a diagnosis very early with EEG. It's just another way of showing how useful EEG can be.
Yes, that's right. Because we had it in one patient because I think it's observed when the child is having those bicycling and boxing movements, or it can be seen in interictly as well.
It's related to the leucine levels. So it doesn't matter whether you have any clinical manifestations. If the levels are really high, then you will see them.
Yeah, we didn't see in this patient, but we had another patient in which we saw that comb-like pattern. Thank you so much for that input.
But great presentation.
Thank you.
Professor Lakshmi?
One comment was the same as Ronnie, so the EEG might give you a clue to the diagnosis. The other one was I was interested that you mentioned, it was a great presentation, Zaveria, that you used mannitol. It's not something I usually use in a neonate, just, yeah.
Because he had bulging fontanelle and the cranial scans showed the face ventricles, and then the blood pressure was high. So we gave a trial only for 3 days and then we stopped it.
Thank you.
Okay, so I think we may have to go to the next case.
Yes.
Well, Dr. Dilek, have you had to say anything, Dr. Dilek?
It was a great case. Thank you very much. We also had consanguineous marriages, a high rate of consanguineous marriages, and see these cases in our country too. The last slide showed the clinical course, and it was very critical to show that the first 7 days and the baby's normal at birth, and then there's a silent period that until the baby has this accumulation of toxic metabolites and then becomes symptomatic. It was a great presentation, and this timeline was also very helpful to understand the mechanisms also.
Thank you so much.
Thank you.
Yeah, I think the next candidate, next presenter, Dr. Archanya from AIMS Rishikesh. And the moderator is Dr. Inder Sharawat. Archanya?
Yes, sir.
Okay.
Is my screen visible, sir?
Yeah.
Yes. Good evening, all. I'll be presenting the case from AIMS Rishikesh, refractory seizures in a baby with resembling Zellweger syndrome under the moderation of Dr. Inder Kumar Sharawat. We have a 5-month-old girl whose baby of S, resident of Haridwar, who's an outborn, was admitted with us on day 10 of life in the NICU. In antenatal history, it was a spontaneous conception, booked and supervised, with third-degree consanguinity was present. The trimester history was uneventful. The level 2 USG showing no gross congenital anomaly, with no history of oligopolyhydramnios or decreased fetal movement. In the natal and postnatal history, the baby was born at term at 40 plus 3 weeks with a birth weight of 2390 gram, which was SGA, was outborn by spontaneous vaginal delivery and cried immediately after birth. The baby had multiple daily left and right focal, clonic, and tonic seizure from day 2 of life. The CSF was done outside, which was non-meningitic, and the baby did not respond to any IV antibiotics and phenobarbital, hence was referred to AIMS Rishikesh. At AIMS Rishikesh, the baby had multiple seizures which were refractory to multiple anti-seizure medications. The episodes were around 10 to 12 episodes per day. It was associated with lethargy, poor feeding, poor vocalization, and paucity of spontaneous movement, and poor suck and swallow. On physical examination, as we can see in the photo, the baby had high forehead, hypertelorism, long philtrum, high arch palate, and was on NG feeds. And on per abdomen examination, hepatomegaly was present. On neurological examination, it revealed central hypotonia with Hammersmith neurological examination showing an optimality score of 25 at term. So in database, we have a neonate with refractory seizures, encephalopathy, central hypotonia, facial dysmorphism, and hepatomegaly. So the differential diagnosis considered were paroxysmal disorders in view of encephalopathy, neonatal seizures, global developmental delay, dysmorphism, central hypotonia, and hepatomegaly. EIMS of FS was also thought of in view of the focal seizures, global developmental delay, and hypotonia. Developmental and epileptic encephalopathy was also considered as a differential in view of seizures, developmental delay, and central hypotonia. Other differential considered was vitamin-responsive epilepsy in view of the refractory seizures, encephalopathy, and developmental delay. However, the child did not have any prolonged seizure or status, and there was poor response to pyridoxine. The final differential considered was structural brain anomalies in view of seizure, developmental delay, and central hypotonia. The continuous amplitude integrated EEG monitoring done in NICU did not show any electroclinical activity. However, the EEG done in the neurology lab revealed a continuous low voltage background with poor reactivity. You can also see frequent independent bilateral focal discharges over the right side more than left, and each ictal discharges was followed by attenuation. On investigation, the CBC, LFT, RFT were normal and the sepsis screen was negative with a normal RBS, ammonia, and lactate. Torch profile was negative. The CSS done outside was non-meningitic. The urine GCMS done revealed all metabolites within normal limits. We went in with an MRI. The MRI brain is showing myelination appropriate for age and no obvious cortical or gyral malformation. And you can also see frontal gliotic changes. On diffusion weighted imaging, the brainstem and splenum of corpus callosum was showing diffusion restriction. A clinical exome sequencing was also sent for the patient meanwhile. So on treatment, the child was not responsive to multiple anti-seizure medications. Initially was started with phenobarbital, followed by levetiracetam and oxcarbazepine, and there was partial response to these anti-seizure medication. We had also started the baby on pyridoxine and folinic acid, and pyridoxal phosphate was planned to be added, which was not available. However, it showed a poor response. On further follow-up visits in the OPD, the seizure control was achieved with hiking up of anti-seizure medications, and the baby is currently seizure-free since last 2 months. Multisensory stimulation was also provided, and the child was continued on exclusive breastfeeding. Meanwhile, the clinical exome sequence reporting was obtained, which showed a homozygous missense mutation in exon 20 of HST17B4 gene, inherited an autosomal recessive pattern, resulting in D bifunctional protein deficiency with a CAD score of 29, suggesting damaging mutation. On follow-up, the baby had was seizure-free with developmental quotient of 40% with a normal vision and hearing. So discussing in brief about this paroxysmal disorder. Paroxysmal disorders is classified into paroxysmal biogenesis disorder and single enzyme or protein deficiency disorders. The paroxysmal biogenesis disorder consists of cell-Weger spectrum disorder and rhizomelic chondrodysplasia punctata. And acyl coenzyme A oxidase deficiency, D bifunctional protein deficiency, and X-linked adrenoleukodystrophy, etc., comes under the single enzyme or protein deficiency disorder. A third category of disorders has also been described, which is due to the disorders of paroxysmal division. As we can see in the picture, there is classical dysmorphic features like high forehead, large anterior fontanelle, separated cranial suture with upward slant of eyes with epicanthic folds, high arch palate seen in this baby. And the Zellweger spectrum disorder and the deep bifunctional protein deficiency are clinically indistinguishable. They can also have hepatomegaly, cholestasis, cirrhosis, biliary dystenosis, and coagulopathy. Neurologically, these babies will be having profound hypotonia with weakness, with hearing and vision impairment, with neonatal seizures, and chondrodysplasia punctata is seen in 50 to 70% of the cases. They can also have cystic kidney disease and pigmentary retinopathy and cataracts. D bifunctional protein deficiency, which was seen in our case, is an autosomal recessive disorder of paroxysmal beta oxidation defect with a prevalence of 1 in 1 lakh. And these are classified into 3 types based on the deficiency of hydratase, dehydratase enzyme. Type 2 is when there is only an isolated hydratase enzyme deficiency, and type 3 is when isolated dehydrogenase enzyme deficiency is present. So the type 1 deficiency is caused due to nonsense frame shift mutations or in-frame deletions, and type 2 is due to missense or missense mutations or in-frame deletions, and type 3 is due to missense mutation or single amino acid deletions in the dehydrogenase domain. A type 4 phenotype has also been described with missense mutation in each enzyme domain with significantly reduced but detectable enzyme activity.
Time is up, please can summarize.
Yes. So there is no cure is still available for this disease, and the treatment is currently symptomatic with avoiding complication, improving nutrition, and providing support for these children. Thank you.
Yeah, interesting case, I'll say. Very, very interesting case. So any comments from the experts?
Inder wants to say something? Moderator.
Good evening, ma'am. This child had initially had high seizure burden and refracted to anti-seizure medication. Later on, the seizure frequency has decreased, and currently he was seizure-free for the past 2 months. The initial MRI showed diffusion-weighted signal changes in the corpus callosum although we do not have any follow-up MRI of this child, but later on the children may develop diffuse white matter signal changes, basal ganglia changes, or cerebellar or cerebral atrophy later on in the life.
Good. Any other comments? Because it's a rare presentation of a rare disease, I'll say.
Although, like in the neonatal period, the facies was not typically of the Zellweger phenotype, but the clinical images at the 5 months of age is showing typical pear-shaped kind of head, high forehead, shallow supraorbital region, long philtrum kind. And the seizures these children may have status epilepticus. They may present with infantile epileptic spasm syndrome, or may have focal or multifocal seizures.
Yeah. So the point is there are no specific clues here, no? That is one major issue in the neonatal period. Professor Lakshmi?
In the for this child, a specific clue for the Zellweger phenotype was some dysmorphism, and hepatomegaly was the soft pointer for the diagnosis. Otherwise, there was no specific clues.
Yeah, that is the thing. So we have to be in the lookout for something, and then our NGS is helping us in this kind of disorders. But the point is, it's a resistant epilepsy. So,
yes, sir.
So, Professor Lakshmi or Dr. Dilip?
Thank you very much. That was awesome. Go ahead.
Sorry. Thank you very much for bringing up inborn errors of metabolism as neonatal as an important etiology for neonatal seizures. In both of these cases, that's what we see. And also in the second case, we see that whole exome sequencing may be helpful in decreasing the diagnostic journey of these patients. Even if there is no treatment, we do have a diagnosis to guide the parents regarding the prognosis of the disease. Thank you very much for this very interesting case.
Yeah, Professor Lakshmi?
Thank you very much. That was very interesting. And as Binan said, even rarer case compared to Zellweger syndrome. Was the pipicolic acid increased?
In there, it was done?
The pipicolic acid, you know how you use that for Zellweger syndrome? It's increased in that. And was it increased in?
No, ma'am, it was not increased.
Okay. Is there a different pathway in this particular mutation?
Ma'am, the very long chain fatty acid would be increased in these children, but we could not send it because it was an expensive test in this child.
Okay, so it was not sent. Okay. So Javeria, you would like to ask a question?
Yeah, I just want to share that we also recently we had a patient with the HSD17B4 mutation, and she passed away at 4 years of age because of refractory seizures, and she also had ovarian dysgenesis because it is one of the association with it. So because of dysmorphism, it can be multisystemic. I just want to say that there is really no cure for this very rare disorder. We have reported this case as well.
Okay, thank you. It's a very interesting case. We'll go to the third one.
Dr. Shehnaz and Dr. Mary, you want to say something quickly?
So that was a great case about Dr. Rajan, and said that program also is not available strictly at Tetrapol Plus and 5-1. So this is not the choice.
Okay. Dr. Shehnaz?
No, I just think that this is very interesting, and as like Lakshmi said, Zellweger is something. These spectrum disorders are are not uncommon, and therefore this is something that one should keep in mind. But again, we also have we don't have VLCFA, we don't have pipicolic acid testing available for us, and so the easier route for us would be just to get a whole genome or a whole exome. So again, these are difficult scenarios sometimes, and like the neonatal EEG, everything that moves is not a seizure. Everything that looks like Zellweger is not Zellweger.
Okay, so that's a great concluding remark there for this case, and we will go into the next case. Okay, from AIIMS New Delhi, Dr. Pooja Jindal. And Prashant, you are there, no?
He's there.
Okay.
Good evening, all. Is my screen visible?
Yes, yes. Go ahead.
I'll be presenting the next case. This case is of Sorry, my screen is not moving.
You can just click once on the screen and then try the forward.
Yeah, it's going now.
So this case is of a 2-month-old baby who was born out of non-consanguineous marriage, who presented at 2 months of age with presentation of seizures since 15 days of life and lethargy and poor feeding for last 2 days before the presentation. At 15 days of life, parents noticed that baby is having episodes of tonic stiffening of right upper limb along with deviation of neck towards right side, along with eye deviation towards right side, followed by crying. These episodes lasted for around 30 seconds. However, the baby was active in between the episodes and was able to fix on mother's face and was feeding well. At onset of illness, baby did not have any history of preceding lethargy or vomiting, no history of fever, no history of vaccination or abnormal body odor or urine odor. Subsequently, during the course of illness, baby had worsening in seizure frequency from initial 1 to 2 episodes per day to 50 to 60 episodes per day. Along with that, there was change in laterality of seizures. Initially, there were right focal seizures. Subsequently, there were onset of left focal seizures as well. This baby was managed outside with multiple anti-seizure medications, despite which there was no improvement in seizure frequency. Along with that, there was worsening in the sensorium in form of lethargy and poor feeding. Antenatal birth history was non-contributory. On examination, vitals were normal. Anthropometric parameters were in normal range. On general examination, baby was lethargic. There were no neurocutaneous markers or dysmorphism. Anterior fontanelle was normal. In CNS examination, baby had poor state-to-state variability. And on motor examination, baby had paucity of movements and central hypotonia. There were no cerebellar or meningeal signs. Primitive reflexes were non-elicitable. So to summarize, we had a 2-month-old baby girl with smooth perinatal transition and neonatal onset of focal tonic seizures with change in laterality and along with progressive encephalopathy without any significant family history of epilepsy. So our syndromic diagnosis was of neonatal onset developmental and epileptic encephalopathy. So we considered the differentials of developmental epileptic encephalopathy with ion channelopathies with higher chances of epilepsy of infancy with migratory focal seizures, SCN2A and KCNQ2 developmental epileptic encephalopathy. These were considered in view of focal seizures with relatively well baby at the onset with change in laterality of seizures. Another possibilities considered were vitamin responsive epilepsies, including pyridoxine dependent epilepsy and PNPO responsive epilepsies. However, these were less likely as a baby did not have any worsening of sensorium initially and there was no response on pyridoxine as well. Other possibilities considered were small molecule IEM, but this was again less likely in view of relatively preserved sensorium at the beginning of the onset of illness. Structural possibility, including cortical malformations, were considered, but again, change in laterality of seizures was against the possibility of structural malformations. So we went ahead with EEG. In this common average referential montage with 10-20 lead system, we could see that there are multiple epileptiform discharges. Along with that, there were new spike-wave discharges arising from the left temporal region, developing into an ictal rhythm. Which was corresponding with clinical correlate in form of right focal seizure. In this similar recording, we saw that there was change in ictal rhythm, which which was previously arising from the left temporal region, which arose from the right temporal region as well, as we can see in this EEG. So we could conclude that there are two separate ictal rhythms arising in the single episode from two different hemispheres. So this was contributing towards the possibility of migratory nature of these ictal rhythms, which was directing towards the diagnosis of epilepsy of infancy with migratory focal seizures. On further investigation, hemogram and biochemical profiles were normal. CSF was non-meningitic with normal lactate and normal CSF glucose. MRI did not show any structural correlate. TMS JCMS profile was also in the normal range. So subsequently, baby was initially managed with anti-seizure medications, which did not lead to any change in seizure frequency. Considering the possibility of EIMFS, baby was started on ketogenic diet and was planned for genetic workup. In clinical exome, there was a pathogenic variation detected in KCNT1 gene, which was pointing towards the diagnosis of epilepsy of infancy with migratory focal seizures. So we concluded with our diagnosis of EIMFS with KCNT1 gene mutation with global developmental delay. We followed up the baby as the baby was started on ketogenic diet. At around 3.5 months of age, there was improvement in seizure frequency from 60 seizures per day to 20 seizures per day. And in subsequent follow-up, baby at 8 months of age, baby had only 4 to 5 seizures per day, which was mounting to 85% reduction in seizure frequency. So at 8 months of age, we can see that although there was significant improvement in seizure frequency, baby already had a developmental delay and there was no improvement in development, even though there was reduction in seizure frequency. So a brief word about EIMFS. As per ILA classification 2022, this is the diagnostic criteria, which shows that EIMFS should have focal or multifocal tonic or clonic seizures, which migrate from one hemisphere to another, and frequency increases in first few weeks or months of the onset of illness. EEG correlate of migratory pattern should also be there. And exclusionary criteria include myoclonic seizures with abnormal neuroimaging. So this.
Please summarize it 6 minutes, sir. Please summarize.
Okay, sir. So in this case, a report, we can see that there was another baby with KCNT1 gene mutation, which was tried on ketogenic diet and quinidine, on which there was no significant improvement. Some case reports show that SCN2A related EIMFS respond better to ketogenic diet as compared to KCNT1 gene mutations. And this was another international multicenter cohort of various cases with KCNT1 mutations, which showed a variable response with quinidine, cannabidiol, and diet therapies. So with this case, we would like to highlight the importance of precision medicine in neonatal seizures. Thank you.
Okay, thank you. So that is adding on to the literature of KCNT1. And I think KCNT1 is not a very rare genetic abnormality, especially I think that international effort also has got a lot of Indian centers participating in that. Lakshmi wanted to comment anything?
Prashant should have said.
Prashant
has to say before Dr. Lakshmi.
Yeah. I'm missing that all the time. Prashant.
No worry, I'm there.
I don't have much to add here. It's just that the initial hype that was there with quinidine when it came, so it's not there. The more cases we get, now we see that it's only a subset where you get a response. And then because of QTC prolongation and the need for continuous Holter monitoring, it is a difficult scenario. So we have a couple of few cases where it has not. In this case, we did try to procure quinidine. It was not available, but then again, we were not so sure of whether to actually start it or not. That is one thing that I would like to just add. Thank you.
Dr. Lakshmi.
I agree with Prashant that the quinidine response in neonates with KCNT1 mutations is not as good as the earlier report suggested. And the second thing to remember is that you can get migratory focal seizures in a lot of other genes. The KCNT1 is the most common gene, but you can get it with sodium channel mutations, you can get it with TBCD mutations, ATP1A2, and I think the list is just increasing. So we need to keep it in mind. And the other thing also, in HIE, you can see focal migrating seizures. But so it is in the clinical context that you think of it as a DEE due to a genetic mutation. Thank you.
Yeah, Dr. Dilek.
Yeah, again, a great case with the clinical semiology, EEG features, and eventually the genetic diagnosis. And thank you very much for this interesting case and emphasizing the importance of precision treatment.
Yeah, so overall, I think I also agree with all our cases. We tried quinidine in 3-4 cases, and then overall response is not that great, especially probably depending on the type. Now they say that sub-precision medicine, you have to look at the type of gene, type of mutation, and some of the mutations have got some response. But overall, this is one of the very resistant epilepsies which we have seen in the recent past after the genetic patterns have emerged. So when you see this kind of a pattern, I think already people are diagnosing that in our group, and KCNT1 is like a spotter. No. Okay, going to the next case. Yeah, AIMS Jodhpur, Dr. Kantha Kumar, and the moderator is Dr. Lokesh Saini.
Early presents future slides. I think there will be some micro precision medicine now. You'll have to go even delve more. Dr. Lakshmi?
That's right. I think we have to find out if it's a gain of function or a loss of function mutation and the subtypes and where they work here. Thank you.
Absolutely. And with the loss of function and gain of function, you have diametrically opposite responses. So very important to understand.
Okay. Yeah, Dr. Kantha Kumar?
Yes, sir. Sir, is my screen visible?
Yes, yes.
And am I audible, sir?
Yeah, proceed.
Yeah, myself, Dr. Kandak Kumar. I'm senior resident from AIMS Jodhpur, and my moderator is Dr. Lokesh Saini, sir. Today, I'll be presenting an interesting case of early onset epileptic encephalopathy. So, we had a 1.5-month-old female baby, resident of Jodhpur, who came with chief complaints of abnormal body movements from birth and excessive irritability and poor feeding since day 1 of life. So, abnormal body movements onset was on the day 1 of life only. These were sudden, jerky, erratic, shock-like movements, predominantly involving the upper limbs. Occasionally, this will involve the lower limbs and trunk also. This is asynchronous in nature, and it is associated with frothing from mouth. Initially, it was 5 to 6 episodes per day, and gradually the frequency was increasing. And currently, it is almost persistent throughout the day, and this occurs independent of. And along with these seizures, the child will be having excessive irritability, poor feeding, and poor quality of sleep. So in this, we can see there is sudden, erratic, jerky-like movements, predominantly involving the upper limb and sometimes the lower limb and trunk also. And this is asynchronous in nature. So this semiology is erratic, fragmentary myoclonus. And there is no history of excessive perception of fetal movements during the antenatal period. There was no history of cyanosis, apnea during these events. There was no history of fever, lethargy, temperature instability, or poor urine output. There was no history of episodic events of vomiting, responsiveness, or rapid breathing. There is no history of abnormal body odor or urine odor. Antenatal history was non-contributory. Prenatally, it was uneven full, and there was no significant history, and this is a product of non-consanguineous marriage, and the child is on NG feeds. So treatment history, when the child presented to us, the child was already on 3 anti-seizure medications, levetiracetam at 60 mg per kg per day, phenobarbital 5 mg per kg per day, and phenytoin at 5 mg per kg per day. On examination, the child was vitally stable with normal pressures. And on focused neurological examination, there was almost near continuous erratic fragmentary myoclonus which is going on. The child was lethargic with poor state-to-state variability. And there was central hypotonia. Power was anti-gravity movements were present with elicitable DTRs. And other systemic examination was within normal limit. On baseline examination investigations, hemogram was normal. Metabolic screen was negative with normal RBS lactate levels. TMS and GCMS was negative. CSF done from the outside hospital was non-meningitic. So we went ahead with EEG. In EEG, we got a burst suppression pattern. So this child fits under early onset epileptic encephalopathy as there was intractable seizures with highly affected higher mental function. And these seizures were refractory to 3 maximum doses of anti-seizure medications. So either it can be a early myoclonic encephalopathy or early infantile epileptic encephalopathy. So in early epileptic encephalopathy, onset will be within 2 weeks. And seizure stimulation, typically we will be getting tonic spasms, which will be occurring in clusters and independent of sleep. And sometimes we can get focal seizures also. In this, we can get burst suppression pattern, but this will occur in a regular rate. And this will coincide with the spasms. Whereas in early myoclonic encephalopathy, onset will be within few hours, and sometimes it can be in antenatal period also. Mother will be perceiving excessive fetal movements, and the typical seizure stimulation will be fragmentary myoclonus, as in our case, which will be asynchronous in nature. And in the subgroup, we will be having burst suppression pattern, but this will be non-continuous, and this will not coincide with the myoclonus, and this will occur more during the sleep. So, syndromic diagnosis, it is fitting under early myoclonic encephalopathy. So coming to the etiological possibilities, structural malformations like corpus callosal agenesis, cortical dysplasia, and hypoxic was considered, but neuroimaging done was normal. And second, we thought of a vitamin-dependent development and epileptic encephalopathy like pyridoxine-dependent epilepsy and PONP. And since the points in favor were onset was on day one, there was typical erratic fragmentary myoclonus, which were refractory to 3 conventional ASMs. And metabolic causes like NKH, mitochondrial disorders, bioadenine deficiency, and organic acidemia was also considered. But the metabolic screen was negative. These EMS were also normal. Genetic causes of EIWE like syntaxing binding protein 1, ARX, ERBB4 were considered, and genetics was also sent for the same. So, course in the ward at the time of presentation to our hospital, the child was already on 3 anti-epileptics. So, IV pyridoxine was given, 100 mg loading, followed by 15 mg per kg per day. Post with the seizure frequency has gradually decreased, but it was in decreasing trend, but still the child used to have some 7 to 8 episodes per day. Meanwhile, we got the genetic report, which showed a pathogenic mutation in PNPO, causing pyridoxamine 5' phosphate oxidase deficiency, inherited in an autosomal recessive pattern. So after this genetic report, we have added the child on pyridoxal 5-phosphate per kg per day. So on 1 year follow-up, the child becomes seizure-free from 5 months of age, and phenytoin and phenobarbital were gradually tapered and stopped. Child was gaining milestones appropriately. A few words on pyridoxine metabolism. So the source can either be from vegetables or from meat, and it is absorbed as pyridoxine or pyridoxamine. With the help of pyridoxine kinase, it will get converted into pyridoxine phosphate. This is the important enzyme, the pyridoxine 5-phosphate oxidase, which converts the vitamin B6 into its active form, which is pyridoxal phosphate, which is taken inside the cell membrane, and it will play an important role in various metabolisms. So, this is exactly the same enzyme which is mutated in our child. So, majority of the patients with classical pyridoxine-dependent epilepsy, they will have mutation in the antiguatine gene, whereas in PNPO deficiency, the onset will be very early, even during the antenatal period. And there are some additional features like prematurity, and there can be delayed cry also with low upguards and excessive irritability, respiratory distress, and even sometimes we can get a parental history of infertility also. And majority of these cases can show improvement to pyridoxine also. So in our case also, initially we have started only on pyridoxine, and seizures has showed a significant reduction. And after adding pyridoxal 5-phosphate, these seizures become passive. So the learning points, yes, sir. The learning points from our cases: early onset epileptic encephalopathy can present within few hours of life, and they'll be refractory to conventional ASMs. Erratic fragmentary myoclonus is seen classically in early myoclonic encephalopathy. In all infants with unexplained seizure disorder, those who are refractory to anti-seizure medications, a sequential trial of vitamins, first pyridoxine followed by pyridoxal 5-phosphate, folinic acid, and biotin should be given. Thank you.
Yeah, great case with a learning, I think a clear message for the residents and fellows, because this is one of the treatable causes of neonatal seizures and neonatal encephalopathy. Anything to add from the moderator? This
Lokesh.
Lokesh.
Good evening, ma'am. Good evening, sir. This case was brought here just to that we should learn that vitamin trials are important, and fragmentary myoclonus, and we have tried to show in that video that this is the classically what it looks like. And once you see it, definitely you should suspect metabolic causes and should give vitamin trial at the earliest. Luckily, we got the treatable cause, but unfortunately, some of the children will not get this treatable, but this trial is warranted. That is what we wanted to highlight. Thank you.
Thank you, Lokesh. That the conclusion is excellent. Professor Lakshmi.
You showed the EG initially had burst suppression. Did it make a difference after the pyridoxine?
Yes, ma'am. Yes, ma'am. Definitely. That is why we were the child was started on pyridoxine, and the seizure has reduced, dramatically reduced. The child was having near continuous seizures, and after that, only 1 or 2 episodes in whole day, and the child is developmentally also looking better. meanwhile, we got the report and we added pyridoxal 5-phosphate also.
But did the EG change?
Yes, ma'am. Yeah, EG changed, ma'am. EG changed. That
Yes.
is why we have.
Okay.
Yeah.
No, it's important to realize that the EG, using the EG as a marker of that this is a PNPO or one of the pyridoxine-dependent epilepsies is you have to be very cautious. There's a good study that's just been published which shows that the EG is not a good tool to use to say, is it a pyridoxine-dependent epilepsy? So we should go on clinical features as well, and whether the EG responds or not, you have to wait till you get the gene test and look at your amino acid profile in the CSF might give you a clue, or even in the plasma amino acids, whether it is a PDE. Thank you.
Yeah, Dr. Dilek.
Yeah, again, great case. Thank you very much for sharing this case. I think the final message on the last slide was very crucial. You may or may not have access to genetic testing, but we should give a try to these pyridoxine. And if clinically we don't have any response, we just should go ahead and try pyridoxal phosphate and folic acid too, until we get the genetic results back. We should give the opportunity of a trial of these vitamins for the babies, because these are treatable metabolic epilepsies. And I just wanted to, it is not related to this case, but because we discussed metabolic epilepsies with onset in newborn period, but I may have missed it, but I just wanted to add molybdenum cofactor deficiency in the differential diagnosis of babies with medical refractory seizures, and also they may have the clinical and MRI picture mimicking HIE. So it's important to remember too.
Yeah, thank you for that comment. And
general comment.
yeah, especially the message is even if there is a partial response to pyridoxine, it is better to try pyridoxal phosphate also in such cases, so that sometimes we may get a kind of initial response to pyridoxine, even though the exact response or a complete control of the seizures and may not be there with pyridoxine. So you continue with the pyridoxal phosphate also in those cases. So that is one message I would like to emphasize here. Lakshmi, you would like to add one more?
Yes, that you have a lot of other conditions that may respond to pyridoxine. The seizures may respond to pyridoxine, which are not due to the gene associated with PNPO or androgen deficiency.
Yeah.
So we need to be aware.
Please continue, Dr. Lakshmi. Please continue, Dr. Lakshmi, please.
Yeah. I think she is done. So any other comments from the
Dr.
experts?
Shehnaz or Dr. Mary?
Dr. Mary, Dr. Mary.
No, I have no comments. It is very interesting.
I'd like to know what you did with the pyridoxine that was given in the beginning. Did you withdraw it? Did you withdraw the pyridoxine given, or you continue only pyridoxal phosphate?
No, we continued pyridoxine.
Also.
Yes, ma'am.
Pyridoxine also, okay. That's all.
Okay. So another thing is that gives, now we are going into a kind of a rapid genomics, which we need at this point is many times when we are not getting that genetic thing, even if we are trying, many times we try at a very low dose and then it may not produce that response. And once we get the genetic abnormality, we can give that kind of a full shot treatment, and which many times gives that result. So there is that's the time for rapid genomics and getting the reports much earlier, rather than this 1 to 1.5 months at this point. That is the turnaround time at this point. So with
we
that,
have the 2 weeks, Dr. Vinay, we have 2 weeks, but they charge a lot.
yeah, that's the thing. Yeah. So In some countries, they have a government program for that that actually cuts down the ICU stay significantly, and the overall cost to the patient is much less. Over to next, the last case from CMC Vellore, Dr. Jiju Jose, and the moderator is Professor Maya Thomas. Dr. Jiju, yes. You are not audible.
Good evening.
Yes.
Good evening, all. Presenting a case from CMC. It's a case of now
you make it slideshow.
Yeah.
It's not full screen, Jiju.
Oh, yeah.
Yes.
Yeah. Okay.
Presenting a case of 3-month-old baby boy. He was born out of third-degree consanguineous marriage and was born at 36 weeks, a preterm labor, and was converted to LSS in view of non-progression of labor, and birth weight was 2.5 kg. Baby died immediately after birth, and at 26 hours of life, he was noticed to be lethargic and was not feeding, and the baby was shifted to NICU. And in NICU, the baby was noticed to have multifocal chronic seizures. And he was treated with a loading loss of phenobarbital. And his initial blood report showed a low calcium, like borderline 7.73 was started on calcium also. But he continued to have seizures. Like he was having chronic seizures and occasional chronic posturing also. He was treated with levetiracetam, phenytoin, and was suspicion of metabolic abnormality was started on mitochondrial regimen also. The baby stopped to have seizures after day 3, but he remained to be encephalopathic. He was lethargic and was having feeding issues and was hypotonic. And again, on 9th day, he had recurrent apnea and desaturation. At that time, his sepsis markers were positive and started on antibiotics and was discontinued after 72 hours. So because of the feeding issues, the baby was discharged on NG feeds, and the genetic test was sent. On examination, the baby was having no dysmorphic features, no neurocutaneous markers, and on examination, he was having bipedal sense in view of in the form of tone increase in both upper and lower limbs. So when he was in NICU, the blood counts were normal. LFT, RFT, ABG was normal. Uric acid was low, and calcium was initially 7.73. Repeat calcium was normal. Magnesium was 2.28. Sodium was normal. CSF done showed WBC 10 and a protein 171 with glucose 88. Serum amino acids done showed a high glutamate and mildly high tyrosine. Organic acid showed elevated lactate. And urine sulfate was done in view of suspicious sulfate oxide deficiency and mold-brain cofactor. It was low. It was 3.61 normal. Homocysteine was low, and serum biotinidase was in the normal level. When the baby was in NICU, amplitude integrating EEG showed burst suppression with seizures, and was having status in between also. So the MRI done at neonatal period showed T2 hyperintensity in the subcortical region and also in the bilateral basic ganglia, and also in the bilateral in the brainstem area also. And there was diffusion restriction involving bilateral subcortical region in the internal capsule, in the peduncle, and also some involving the thalamus also. So this was the MRS. MRS was showing a lactate peak, and also there was a peak at around 2 that area was suspicious of glutamate also. So the probable diagnosis we were considering here, one was mold-brain cofactor deficiency, and second was sulfate oxidase deficiency. Then the pyridoxine-dependent epilepsy and hypoxemic encephalopathy were all under consideration. So all exome sequencing was done that time, and report came as MOCS2, that is mold-brain cofactor deficiency, which was autosomal recessive, homozygous, that was reported as VUS. Now the validation done for the child and the validation report is pending. So currently the child is under follow. He's having delay 3 months and having no seizures at present. On stabilized on 2 antiepileptics, stabilized on 2 antiepileptics, and having feeding issues, continuing on NG feeding. Regarding modular cofactor deficiency, it's a spectrum disorder with the early severe variant, which is our baby is having, with presenting with severe neonatal encephalopathy. And it was having a late onset mild variant also, with present with usually decompensation with acute illness in the later life, can present with dystonia, can present with acute encephalopathy also. And the main mechanism is it's required for the activity of sulfate oxidase enzyme, and the metabolic abnormality is caused due to the sulfate, which is accumulating and causing the toxicity. And the main diagnosis is genetic only, and also it shows biochemical abnormalities like reduced sulfate and reduced homocysteine, reduced uric acid. I can get different gene abnormalities: GPHN, MOCSC1, MOCSC2, and MOCS3. And in case you can get reduced activity sulfase oxidase in cultured fibroblasts also. Mainly treatment is mainly supportive care. You address the feeding issues, thiamine supplementation, thiamine deficient patients. Avoid valproate because it can cause mitochondrial toxicity. And treatment of spasticity and dystonia. And for there's a targeted therapy for MOSC1 in the form of cosidinopterin that helps in the pathway of the molecular cofactor deficiency, molecular cofactor synthesis. Thank you.
Professor Maya.
Yeah, thank you, Jiju, for that presentation. So I actually
Jiju,
hear
stop sharing. Stop sharing, Jiju.
Sure.
As Dr. Dilek just mentioned, this is one of the important differential diagnosis for HI. Only thing, the child did not have history to suggest any hypoxia and started symptoms meaning at 26 hours of life. But the MRI, as you can see, was suggestive of global hypoxia with involvement of both the cortical, the deep nuclei, and as well as there is relative sparing of the brainstem. That is again rather typical of this molybdenum cofactor deficiency. Of course, our child was, effectively managed by the neonatal team. We are not allowed anywhere near there because they are they are very good, and they are very good at their EEG, AI AEGs. So, but we do see them on follow up. Of course, now the child has got spastic quadriparesis, issues with feeding. Seizures are under control. I think Dr. Shahnaz has something to say. Comment?
Yes, thank you very much. That was a very interesting presentation. My only thing to add to this would be that in addition to children without any specific history of HIE would be that uric acid, which was low. And because molybdenum is the cofactor for xanthine oxidase also, and sulfite oxidase. So in places where we really can't get any access to genetic testing easily, then uric acid would be something that could help at least make more of a clinical diagnosis, and that would be raise your suspicion more for a molybdenum cofactor rather than sulfite oxidase, pure sulfite oxidase deficiency. The second question is, molybdenum is available in some parts, of course not in Pakistan, but is it available in India to give to the children with molybdenum cofactor deficiency?
Not that I know of, actually. We do try something like a low protein diet, but again, in a newborn, that's not practical either.
Okay.
Yeah.
And just to add to the last case, Shefali, for the pyridoxine PDE, we usually give a low lysine diet also. So I don't know if that particular child was given low lysine along with the PNPO, although that was PNPO, but PDE usually require low lysine because the cognition improves better, they say, with and the intellectual growth is better with giving them low lysine diet. Thank you.
Should I say something?
Yes, Dr. Lakshmi, please go ahead.
And just clinically, this is one of the conditions where you may see hyperplexia in babies with this neonate habit.
Meaning, we actually didn't manage the child in the acute phase, but as per the records, it was just multifocal chronic seizures from 26 hours of life, which persisted for about almost 48 hours. Meaning there's no record of hyperplexia being noted.
Dr. Dilek?
Yeah, thank you very much for this very important case. It's an example of, one of the scenarios when baseline laboratory investigations may have hints for an underlying metabolic disorder. And again, if you miss this case as an HIE case, then the parents may end up having another affected child. So it was a very great teaching case. Thank you very much for sharing.
Thank you. Lokesh has to say something. He's raised.
Ma'am, ma'am has commented about uric acid, low uric acid. So we also use low homocysteine. This was done in our case. This case.
Yeah, this child had both low homocysteine as well as low uric acid.
So low homocysteine is a very good marker, especially for
absolutely.
vegetarian diets, because in our children we see high homocysteine levels.
That's
in
right.
infants, especially because of prevalent B12 deficiency. So if we find low homocysteine levels in any infant, this is a indirect, like even for late onset sulfite oxidase, it is a good marker. Where MRI patterns are like different, only GP hyperintensities we find sometimes.
Okay, thank you, Lokesh. That is a great clinical clue for all of us and all the residents. And especially, as he rightly told, when there is a high vegetarianism in some parts of India. So this will be a great clue. So with that, I think that is
we have to come to an end.
Yeah,
no,
it's a very long session.
I know we are, actually we are 53 minutes. We have extended time, but I'm very sorry about that, but there were a lot of interest and participation for presenting cases. We now want to request the experts and the moderator to give take-home messages, and then we wind. It will be 30-second take-home messages. Dr. Lakshmi, then Dr. Dilek, then Dr. Shehnaz, then Dr. Mairi, and then the moderator, Vinay and Dr. Lakshmi.
Thank you very much. They were great cases and good to illustrate, some of them very rare, but that you should remember that they do occur, and especially when specific therapies are available, it is important for us to diagnose and treat early. Well presented. Thank you.
Thank you. Dr. Shehnaz.
Thank you very much, everybody, for the excellent presentations. It's something that reminds us that these cases are not as rare as we think of them, and especially in countries with high consanguinity, even without consanguinity, the metabolic disorders presenting early neonates are very, very important because some of them are very treatable. Thank you again for the invite, and thank you, Shefali, for this event management. Thank you.
Thank you. Dr. Dilek.
Yeah, again, thank you very much for these great cases, differential diagnosis, and detailed discussions. But I learned a lot. I enjoyed a lot. And again, I share the same messages with the other experts. It's important to diagnose particularly the treatable metabolic disorders. And even if we do not have a specific treatment at this point, it's important to give genetic consult provide consult for the parents.
Thank you. Dr. Mary.
We should not get tired of diagnosing. This session will help us remember to diagnose. It will help not only in the treatment, but also in genetic counseling, which will prevent birth of similar children in the family.
Dr. Maya?
Thank you all. It was a good learning experience. And I think we had an array of, metabolic small molecule disorders with intoxication, energy deficiency, complex disorders involving complex molecules, the peroxisomal disorder. So there's a variety of, cases presenting with the neonatal seizures.
Thank you.
Thank you.
Vinay.
Yeah, nothing to add. So thank you, AOCN, for providing this platform, and then it was a nice learning experience, I'll say. I think at the end of the day, we also got some points to take it into our day-to-day practice. So that
Absolutely.
Yeah, that is
Thank you. Thank you, Vinay.
That is the
Thank
most
you so
important
much,
part of
Vinay.
this.
Thank you.
Thank you, Shukran.
One second, Mahesh.
Yes,
Definitely
ma'am.
has to say
Yes, ma'am.
any take home message.
No, ma'am. It was really a nice discussion. Very interesting cases were presented. It was
I
a
would
nice
like
discussion,
to,
ma'am.
thank you, Mahesh. Before you announce for the next week, I just want to thank all the Dr. Ronit and all the experts and all the attendees and Dr. Vinay for moderating. And I think, Mahesh, you can talk about the next and very, very well presented. All the cases were very well presented, and we're very happy that we had presentation also from Pakistan, and all of them were very, very well prepared and very well presented. And Mahesh, you can announce for the next.
Yeah, and next 2 Wednesdays we'll be having discussion on fetal neurology. So I'll be putting the details of the webinar and the case presentations in the WhatsApp group and emailing all of you. Please attend in good numbers. Thank you. Good night.
Thank you. Good night. Good night. Bye-bye. Bye. Thanks a lot.